Okay, great. Good afternoon, everyone. Welcome to the second webinar in a new series from the Better Health and Care Hub at KCL. I'm Glenn Robert, one of the co-directors of the Hub and Professor of Healthcare Quality and Innovation in the Faculty of Nursing, Midwifery and Palliative Care. If you're new to the Hub, then Abby will be posting a link to our webpage in the Q&A space, as well as links to our social media profiles. But in short, the Better Health and Care Hub is a cross-faculty initiative at King's for research and education, with an initial 5-year programme seeking to improve health and care with a focus on complexity and unmet needs. We have arranged the work in the Hub into 3 clusters called Care Force, Frugal Innovation and Communities. And today's webinar will focus on the first and last of those clusters. So in terms of Care Force, we'll be hearing a talk relating to providing better support to informal carers of people with severe breathlessness. And in relation to communities, the talk will focus on discussing a theoretical methodological contribution that seeks to enhance the effectiveness and sustainability of collaborative group working in the health and social care sectors. I've been given a few brief housekeeping notices before we start. So just to say, to avoid any possible disruptions, cameras and microphones will be switched off during the 2 talks, but we'll also be switching those back on again during the Q&A session. That Q&A session will take place after both presentations have been made. Each of the presentations will last about 20 minutes, and then we'll open for questions and comments and finish the webinar by about 2 o'clock. If you're familiar with the Q&A function in Teams, then this is open, so you can also pop any question in there throughout, and that's where Abby will be posting the various links. The chat is also being monitored throughout as well, so if there's any comments, please do pop them in there. And finally, a reminder, the event is being recorded and will be made available to those who registered but were unfortunately not able to attend today. Okay, great. So without further ado, it's my pleasure now to introduce our first talk by Eleanor Rochester, a research assistant in the Cicely Saunders Institute for Palliative Care and Rehabilitation. Eleanor will be discussing the ConnectCare project she's currently working on. So over to you, Eleanor. Thanks.
Great. Thank you so much, Glenn. Give me just a second to get my slides up. Lovely, thank you. So good afternoon, everyone. Thanks so much to Glenn and to Abby and everyone at the Better Health and Care Hub for the opportunity to speak with you all today. So I'm going to talk about some work I've done over the past year, led by Professor Irene Higginson, along with many other collaborators. And this is about how to find out how we can make meaningful change for unpaid carers of people with breathlessness. Unpaid carers are absolutely key to our health and social care system, but we know that they're often not getting the recognition or the support that they deserve. And over the past year, we've spoken to a number of carers of people with breathlessness, and I'm really excited to share with you what we've learned from them, as well as what we've learned from some review work we've done. And I will also share a bit about where we're hoping to go next with this work. So I'd first like to invite you all to consider the concept of the care force. So this concept expands the definition of the health and social care workforce to include not just professionals, but also people who are ill themselves, as well as their families and their broader support networks. And this data on the screen is from Carers UK from 2021. And what it really highlights here is that they have calculated that if the care provided by our unpaid carers here in the UK were provided by paid professionals, it would cost us, the taxpayers, around £184 billion a year. This is roughly the whole NHS budget. So when we zoom out and we look at the healthcare workforce more holistically, and we really consider everyone who is contributing to it, it might lead us to think a bit differently about how we might design the health and care system that we need for the future. So for us, this brings up 2 major questions. What knowledge, skills, and support do carers need to perform their roles well and also maintain their own well-being? And how can we make sure that the support, information, and training actually reaches the carers who need it? So we've started with a focus on those who look after people with breathlessness. And breathlessness is one of the more common and distressing symptoms in people with advanced disease. We know from previous research that carers of people, for example, at the end of life, rate breathlessness as one of the most difficult symptoms for them to manage. It's really distressing for patients and their families, and it impacts quality of life. It can prevent people from doing the activities that they enjoy, and it's unpredictable, so it can really impact planning for the future. Breathlessness is a big driver of strain on the healthcare system. It's associated with repeated hospitalizations and ED visits. And even when someone's underlying disease is well managed, breathlessness can still keep getting worse. So that's why for a few years now, excuse me, at the CSI, there's been a focus on designing symptom-focused services for people with breathlessness with different conditions, supporting them to learn self-management strategies. And here, just a couple examples on the screen. One of them is an ongoing trial, Self-Breathe, which is a online self-management platform for people with breathlessness being led by Dr. Charles Riley. And from services we've developed at CSI and many other services, we've learned that breathlessness is a symptom that can be managed with some fairly simple techniques. And that if patients and families are empowered with information about breathlessness and about how to use certain techniques, um, it can really improve the symptom, and it can also potentially improve people's anxiety, their quality of life, and potentially reduce healthcare costs. But if we are going to empower patients with this knowledge about self-management, we absolutely have to bring their family and their carers into that conversation as well. So last year we had some seed funding to explore the priorities of this particular group of carers. We knew that they would be facing many challenges, and we really wanted to learn what was most important for them for us to tackle first. So we conducted 2 workshops with 18 carers of people living with breathlessness due to different respiratory conditions. Um, and the aim was, yes, to understand what they would like us to tackle first through research. Also, I use the term carer throughout this presentation with the understanding that not all people with caring responsibilities really identify with this term, which is part of the challenge inherent in providing services to them. So these workshops were a mix of open discussions, contributing to a virtual whiteboard, and polling questions where we asked carers about how supported they feel in different areas. And what we learned from participants is also supported by previous research, that watching someone you love struggling to breathe is highly distressing. It's upsetting, it's unsettling, and it can leave people in a constant state of anxiety and hypervigilance. Carers also describe challenges in their relationship with the person they help look after. They don't always see eye to eye on what needs to happen for their care. And they describe feeling ignored by health professionals and really shut out of important discussions. And this feeling of being ignored by health professionals made all of these other challenges more difficult to deal with. Also from the polling questions, less than half of the carers said that they knew about resources available to them in their communities, or other resources to find sort of financial or practical support. And most said they didn't have never gotten any support to navigate changes in their relationship from their caring role or to plan for the future with their relative. So 3 priorities emerged from these workshops after sort of discussing and feeding this back with the carers. First, they want more resources to understand their relative's illness and to plan for the future. They want greater understanding and respect from health professionals. And they want support for their own mental well-being. And in particular, they suggested that just opportunities to connect with other carers in similar situations would be really helpful to them. So we were lucky to also have a graphic artist named Joel Cooper attend these workshops. And this artwork represents the reasons that the participants identified for their distress and their anxiety around their relative's breathlessness. I won't linger with it too long, but I would encourage you to come back to this in the slides following. So alongside these workshops, we conducted a scoping review of interventions for carers of people with breathlessness. This included lung cancer, COPD, interstitial lung diseases, and other people with symptomatic breathlessness. We found 72 unique interventions in 19 countries since 2000, and only 8 of these were done in lower middle income countries. They covered a really wide range of approaches, but broadly, there was a split between some interventions which were focused on directly supporting carers, so things like counseling, coaching, group support, and then interventions that were trying to improve patient care. So, for example, bringing caregivers into pulmonary rehabilitation and then evaluating the benefits of that for both the patients and their families. Some major findings from this. One headline was that there has been very little done for COPD carers and even less for interstitial lung disease carers compared to lung cancer carers. And this is an issue because we expect the burden of COPD to increase dramatically over the next decade. We also didn't find a lot of evidence about how these different approaches might impact different groups. A lot of interventions did not report demographics for participating carers, so we don't know whether these approaches might work well for carers who are in poverty, who have lower literacy, or who are from different cultural backgrounds. And we didn't find a lot of evidence on the actual reach of these interventions. So we found a pile of approaches that, when trialed, do potentially improve outcomes that matter most to carers, but there's still a big question mark about which of these could actually be implemented in practice and sustained. So based on this, we decided going forward we would focus on COPD caregivers and ILD caregivers since they've been really overlooked. But beyond that, once we finished the review, we were a little stuck about where to go next. So we had another workshop with 3 of the carers we'd previously spoken to, and they all look after someone with COPD. And we asked them what they thought about the findings from our review. They brought up a few really interesting points. One was around stigma and the impact that they as family members feel from health professionals potentially stigmatizing people with COPD. They felt this might be why there's been less sort of attention paid to COPD carers. And another finding was that, again, they mentioned feeling generally ignored by health professionals, and they said they don't receive a lot of signposting or any signposting to resources from professionals. They do seek out information on their own online, and they did say that there's good information about COPD specifically online, but that they do sometimes have challenges sorting through it, and there's also not much around practical skills or strategies for managing symptoms. Um, and so um, they said to us it would be really helpful to have kind of one comprehensive online one-stop shop where they can find this quality information and maybe connect with other carers, maybe be signposted to things in their community. And so we thought, great, we'll make them an app, we'll make them a website, we'll co-design something that will solve all of their problems. But then when we sort of took a step back and thought about it more, we realized that we do know there are already resources that look a lot like what these carers were describing that they wanted. We looked into it a bit more deeply, and we found these and more online resources from reputable sources for carers of people with breathlessness specifically, or patient-focused resources that fulfill a lot of what the carers were asking for. But none of the carers we spoke to were really aware of any of these, and we'd be really interested in seeing sort of how that bears out among a wider group of carers of people with breathlessness, because we're aware we've only spoken to a fairly small group of people. So we know that there are opportunities for support groups for finding information about symptom management. So the problem may be not that there aren't resources that exist, but that the carers that need them might not be aware of them. There are no consistent times or events when they would be referred to support. And so we decided that the disconnect between carers of people with breathlessness and resources already out there is the problem that we need to try to better understand and address. So we are now preparing a funding application for the CareConnect project. And we plan to make care co-applicants who we've been working with throughout this process really key to developing this. We're also excited to be collaborating with Asthma and Lung UK and hopefully others soon. And our aims are really to understand the barriers to help seeking or to accessing resources for carers of people with COPD and other conditions that cause breathlessness, both sort of personal barriers and more systemic barriers. We're going to see what we can learn about how carers are already engaging with these resources, where they go for support and information in the real world, and we'll focus on working with carers from specific communities that are most impacted by breathlessness to see how we might need to tailor or adapt existing resources to work better for them. For example, to ensure cultural appropriateness or to meet the needs of digitally excluded caregivers, those with low literacy, etc. And our ultimate goal is to identify who in the system is best placed to signpost these carers to support, and then figure out how to actually make that happen. So finally, I would like to close by sharing a few learnings that we've had, or that I've had, from speaking with caregivers over the past year and a half. If you've worked with family carers, these will probably be quite familiar to you, as they tend to have the same sort of needs across different settings. But these are things we can all do as clinicians or as researchers to make life a little better for unpaid carers. So as much as you can, trying to treat carers as part of the care team and recognizing the role that they play in the healthcare team. Maybe familiarizing yourself with support that's available in your community and with these national resources. Checking in with carers. The carers we spoke with mentioned that they never were really asked how they were doing by either their own doctors referring to their caring role or by their family members' doctors. And then for researchers, I think it's really important that we include carers in designing interventions that are meant to improve things for patients, and really consider how a service you're developing might impact families, how you can include families in developing that, in making sure that it's as effective as possible. And then when you're reporting that research, just from me, to please report the demographics of the carers and report them separately from the patients. Finally, I'd just like to share a list of the collaborators we've been lucky enough to work with the different stages of these projects, many of whom are also collaborating on our upcoming funding submission. And thank you all so much for taking the time to hear about this ongoing work. I really hope that you will take some of this to better support the carers in your own life. They really are fabulous and they just deserve the world from the healthcare system. And I'm happy to take any questions at the end, but I believe now it is time to hand back over to Glenn to hear about his work. So, thank you all so much.
Thanks, Eleanor. That's great. And yes, we'll have plenty of time after the second talk for any questions or comments you may have for Eleanor. If in the meantime you want to post them in the Q&A, that's fine, or you can just raise your hand when we come to the open space at the end in the usual way. Thank you very much, Eleanor. Okay, I'm now going to hand over to the second presenter, who happens to be me. So I'm just going to change hats and share my slides. Just give me a second. Great. Hopefully you can see those slides. Eleanor, if you nod your head, I'll know that the slides are looking good. Great. Okay, fantastic. So this is our second talk today. And in keeping with the title of the presentation, this has very much been a collaborative effort involving Dr. Ollie Williams, who's on the call, actually a lecturer at King's in our faculty, and also Bertil Lindenfeldt, who's a lecturer at Jönköping University in Sweden. And the rationale for our work is really based on the fact that public bodies and civil society organisations are increasingly having to rely on multi-organisational, multi-stakeholder collaborations to address complex societal issues. And obviously that's very much fitting the brief of the Better Health and Care Hub. But evaluations of these types of collaborations, multi-organisational, multi-stakeholders, typically show they often fail to improve health and care, certainly to the extent originally anticipated, and may even have negative consequences for those involved, for example, patient and public members. And because of this, creating ways for researchers, members of the public, patients, carers, decision makers, and communities to form more meaningful, effective, and fair partnerships became the focus of our research. So between us, we set to the task of exploring potential bodies or previous work that might help with informing this task. And that took us to the work of Eleanor. So Ostrom was a political economist in the US who was the first woman to win the Nobel Prize for economics for her book Governing the Commons, which was published in 1990. And essentially, Ostrom's Governing the Commons illustrated that certain conditions help facilitate local communities, groups of people to sustainably manage what she called common pool resources. So she defined common pool resources as consisting of natural, human-made resource systems, things like irrigation systems, forests, pastures, fisheries, where it's costly but not impossible to exclude potential beneficiaries from obtaining benefits from its use. And the argument was that without such management, these resources are susceptible to over and or ill use, and that can have detrimental social, ecological consequences. This harks back to Garrett Hardin's work, earlier work around the tragedy of the commons, which described how individuals, if they're acting independently and rationally in their own self-interest, can deplete or degrade shared resources that are otherwise open to all. And at the time, it was thought that the management of these types of resources could only be successfully done in one of two ways. One was through state intervention, state ownership of these types of resources, or the second through the free hand of the market. But what Erstrom's work shows, through some really fascinating observational work all around the world of these local communities coming together to manage these common pool resources, was that there was this different third way. And so there's a whole series of international case studies that form the empirical work behind governing the commons. And so to sort of represent some of the principles underpinning Erstrom's work, so there's a nice quote: "There is no reason to believe that bureaucrats and politicians, no matter how well-meaning, are better at solving problems than the people on the spot, who have the strongest incentive to get the solution right." So from her work, and published in Governing the Commons, Erstrom suggested the presence or absence of these 8 design principles helped explain why local communities were able to manage shared resources in a sustainable way. Now, Erstrom was a political economist, and she writes as a political economist. So some of these principles are not perhaps the most accessible, and it's challenging to think how we might be able to translate them into applied health services research or applied research in the health and social care sectors in a way that would help these collaborations to be more effective. So essentially, the work that Bertololi and I have been doing is a translation one, and moving from this Erstrom's empirical work and her theoretical work, and translating it into practice. Can we create resources and tools to help groups become more effective based on the excellent research that Erstrom and colleagues conducted? And I'll come back to that in a moment in the presentation. Just a couple of things to add to Erstrom's original work. So a later paper, 20 years after the publication of the book, Cox et al. Did some retrospective evaluation of the 8 principles. They've reviewed 91 empirical studies since Erstrom's original work and suggested that that review provided strong empirical support for the efficacy of these 8 core design principles. And then later in 2013, and Ostrom was a co-author on this paper. This is one of the last papers she published, actually. Said that given such a strong foundation of theoretical and empirical support, the core design principles can potentially serve as a practical guide, for increasing the efficacy of groups in real-world settings. We encourage others to use the principles as a practical guide for improving the efficacy of groups. And it was this final sentence in this paper, in this quote here, that attracted Ollie Bertel and I particularly to Erstrom's work. So encouraging others to use these principles as a practical guide for improving the efficacy of groups. And we thought that's interesting. There's potential here for translating this work into tools and resources that can be applied and used in the health and social care sector to enhance the effectiveness of these inter-organizational, multi-stakeholder collaboration. That's all great, but how do you do that? And that's the work that we've been doing together. So we started off as others have done with the paper on the left here. This is a retrospective analysis of a co-design study that I was marginally involved in Los Angeles County, where we were working with formerly incarcerated prisoners who were being released and co-designing pathways for them to re-enter health and social care services. So as others have done, we looked at this co-design project, which is a form of collaborative group working, and applied Erstrom's principles to see whether they were present or absent in this particular initiative, this particular case study. We found that 4 of the principles were inherently there in this co-design project, but 4 were not. And the 4 that weren't were particularly related to the more kind of systemic factors and features that might shape the effectiveness of collaborative group working. So we felt that there was potential, had the principles been applied in this case study prospectively, it might have been more effective had that been done. The second paper in the middle is a more theoretical piece, and it makes the argument that if collaborative group working initiatives such as co-design are practiced poorly, then they may lead to what actually Ollie termed tragedies of co-design, and a hark back to Harding's work around tragedies of the commons. So mainly to tragedies of co-design, and actually create disvalue if co-design is practiced poorly. And we're making the argument that Erstrom's design principles could help mitigate those instances of creating disvalue if there are poor practices being used in the context of co-design. And then the final paper on the right is actually the first prospective study that we did. This was with funding from an ESRC methodological innovation grant. So we worked for 16 months with a user-led organisation of disabled people. They had a national lottery grant. They were engaged in developing new national services for disabled people. We worked with them for 16 months to see whether it would be useful for them to prospectively apply Erstrom's principles to that initiative and to their group working. We learned an awful lot of lessons in that project. We, as in the research team, definitely made some mistakes in how we introduced the principles and some of the language we used when doing so. But by the end of the project, by the end of the 16 months, there did seem to be some value recognised by the members of the user-led organisation in how the principles could be used as a reflective tool, as a heuristic, to change their thinking and some of the things they were doing as part of that project. So we did those pieces of work, but then we set to really thinking about how do we get to apply this in practice. So we've done 12 interactive workshops in 5 countries so far with various participants, and where we've landed up, to cut a very long story short, is that we've rewritten those 8 original Erstrom principles into the 8 you see here with the iconography at the top of the slide. So we've rewritten them as understanding, fairness, unity, openness, motivation, differences, influence, and mapping. And I'll just give you an example of how we did this translational exercise in the context of the first of Erstrom's principles. So Erstrom's original phrasing for this first principle was clearly defined boundaries, the identity of the group and the boundaries of the shared resource are clearly delineated. So the first step we did was, as researchers, Ollie Birtle and myself, we went through several iterations of turning each of Ersham's original principles into "this will help you to" statements. So this was our first kind of stepping stone to making the principles more accessible and applicable in practice. And in this case, we ended up with a rewrite of "this will help you to identify what unites you as a group, agree your shared purpose, understand how the wider system is relevant to what you're trying to do, and whether you need additional members to achieve your goals." And then, having gone through several iterations of that, we worked in some of our user workshops to develop a principle card relating to each of the principles. So in this case, and we took the researchers' rewrite, we worked in the user workshops to take this down to a card titled "Understanding," with a tagline of "Knowing the purpose that unites you, understanding the resources you share." And then on the back of that card, you can see more explanation about this particular principle. So we did that obviously for each of the 8 principles, and we ended up with 8 principle cards in exactly that type of format. But that still doesn't help us or groups that might want to work with these resources to actually enact the principles in practice. So the next step that we've done is to develop what we're calling activity cards. So these are activities that the groups can undertake which retain the logic of Ersham's principles without referring back to her original formulation. So we currently have 28 activity cards. We may develop a few more, and you can see them all here, and they relate to one or more of the 8 principles. And the exercise we're engaged in now is creating some pathways to help groups put this theory into practice through the use of these activity cards. So just to give you an orientation to the cards themselves, each of them outline the activity at hand, the instructions for completing it, and which principle it is practicing. So you see an example here, extra, adapting your story to your audience, relating to the understanding and the mapping principles. Each card features an activity title, an introduction line, and a brief doodle. So this one, "The Moon or a Mile Away," is relating to what's the level of ambition of the group, what's their aspirations for their work together. And you can see that it relates to 2 of the principles on the bottom left. And then on the back of the card, there are instructions for each activity. They include some text that's highlighted in bold for quick reference. So in this case, identify the scale of impact you're currently aiming for. Will you affect things locally, nationally, globally? If your goals are hospital related, will you impact your local hospital, the nation's hospitals, all hospitals, the future of hospitals, etc. Each card tells the user at the bottom the corresponding activity sheet number, and I'll illustrate some of those in just a moment. The activity sheets, how many sheets they'll need to print, and a suggested time duration for the exercise. So alongside those activity cards, we've produced some activity sheets. These are very much still in prototype form. They're just at the moment in the form of A4, A3 sheets. But these are really to help facilitate discussion around the activities, the activity cards they relate to help with implementing changes in group processes or decision making, but also importantly to create group reference points, because one of the things we think is very important is that groups continually come back to these principles as they're working through an initiative or a project. So creating those group reference points, those sort of touchstones they can come back to and refer to, is very important. Where we're at now is doing some user testing. This was just a few weeks ago in London. So we want to create some sort of model pathways for how you can use the activities which link back directly to the principles in particular scenarios. So this is an example of one scenario we've been working with. We've done this with 4 groups now. So the scenario is there's a new group forming to address a pressing health and social care issue. You're all coming together for the first time. It's an away day. It's 9 to 5. Which group activities would you do, and in what order, to get the most out of the day and get the group off to a good start? So this is really harking back to the point I made right at the beginning, that in these multi-organizational, multi-stakeholder collaborations in the health and social care sector, we don't often at the beginning pay enough attention to how groups are actually going to work in practice. What are the kind of formal and informal rules and kind of group dynamics that we're looking to achieve? So we need to think about those things much more carefully at the beginning of these types of collaborative group working initiatives. And you see here in the photo on the right of the slide, one of the groups have scheduled their activities throughout the day, 9 till 5. And obviously one of the things we're interested in is we've done this with 4 different groups, and we're looking for different patterns in how they use the activities, similarities and differences for the activities that they'd schedule at different parts of the day, or indeed within the day at all. So you may just be able to spot the top left at 9 a.m. This group is starting very much with the fairness principle. So the yellow icon, which is the sunflower, and the bee, that features very heavily. They felt that was important, that the issues of fairness were important to start the day with. And then if you look down to sort of 3 o'clock, 4 o'clock in the day, they're thinking much more around the principles around influence and mapping. That's the blue and red cards. And as I say, we're comparing, contrasting the different pathways that different groups are coming up with in this same scenario. And the idea is that we will be able to then offer these pathways as suggested routes through for groups to work with the activities. And the second scenario we're working with, this was in Denmark last week with some very smart PhD students. So your PhD project relies on the involvement of various stakeholders. 12 months into the project, various people are starting to drop out. You've managed to schedule a 2-hour in-person meeting, which everyone has agreed to join, to address these issues and reset the project. Which group activities would you do, and in what order to get the most out of your time? So a very different scenario. This is a 2 hours around a PhD project. The project's hit a few bumps in the road. Can the activities be usefully used to get this project back on the road? Again, we worked with 4 groups in Denmark, and this is just an example of one of them. So these are the 6 activities that they chose, that they felt would be helpful in this particular scenario. Interestingly, in here, they've highlighted the openness, the principle, the one with the desk lamp icon, which didn't feature at all in the scenario 1 because that wasn't seen as relevant to that particular scenario. So it's a good example of how these different scenarios mean that the use of activities is highly contingent on those contexts. So that's where we are at the moment. We're working through various scenarios. We're comparing the pathways that the various groups are coming up with. In terms of next steps, so as I say, we're co-creating these preset pathways or activities that we suggest will be useful in certain scenarios context. I'm pleased to say that last week we heard that we have been awarded an ESRC Impact Acceleration Account Award, which will allow us between now and probably late autumn, the end of this year, to fully digitalize the physical resource. We just have physical prototypes at the moment in the form of the cards. That digitalization is going to be complete with an interactive user interface and a instructional video, which will walk the user through how to use that resource. And obviously what we're keen to do is then to pilot research and evaluate the effectiveness of the resource and in whether it achieves our own ambitions of enhancing the effectiveness of multi-stakeholder, multi-organizational collaborations in the health and social care sector. I mean, I think the final point, just got time to make the final point. Final point to remember is what we've tried to do throughout all of this is to retain the underlying logic of Erstrom's original work in this translational piece that we've done to produce these resources and tools. And I think that's very important. And as part of that, a key feature of Erstrom's work is the interaction between these 8 principles. And you see that in some of the scenario examples I gave you, where the groups were combining different principles at different points in the day. I hope that's been helpful and of interest. If you'd like to help us test the resources, please do get in touch. All feedback is welcome at this stage. It's been a really highly iterative, interactive process to get us here, and we'd like to continue in that vein. Thanks to our various funders, and you've got our email contacts there. So please do get in touch if that's of interest and you'd like to learn more. Okay, I will stop sharing. Yep. Oops, lost everything now. There we go. Great. Got you back. Okay. So we've got bang on 20 minutes, as we promised, for discussion or questions. I think Abby is going to provide camera and mic access. She's just done that. Fantastic. So we've got time for any questions or comments on the presentations. Perhaps if we take any questions or comments for Eleanor on her ConnectCare project first, because you've had more time to think of those. So if anyone has any questions, you can either raise a hand or I can quickly chat the Q&A. I don't know if you've had a quick look at the Q&A and there's any questions there, Eleanor. Minera, thank you.
Thank you. Can you hear me?
Oh, yes.
Now. Yeah. Thank you both for great presentations, really important work. My question for Eleanor is that while I imagine that some aspects like identifying barriers to support, especially for ethnic minority groups, as you said, or facilitating carer connections, it might be transferable to other long-term conditions. I'd be really interested to hear your reflections on that. So are there any particular elements that you feel are more widely applicable to other populations or others that are highly condition specific to like COPD or ILD? Because I think this work could be quite relevant to other carer populations as well. Thank you.
Thanks, Munira. Thanks, Munira. There you go. So yes, you're absolutely right. And I think definitely sort of Irene's broader ambitions for this is that the next stage of this work will develop some really transferable methods of engaging with carers and kind of try a few different techniques for getting their feedback and their input onto this and have some knowledge about what ways are most effective at really engaging them, at meeting them where they're at with their sort of specific responsibilities and life circumstances and carers from different communities as well. So that's one sort of methodological thing that we're really hoping we can contribute to from this. And yeah, as people who've worked with carers will probably know, they have a lot of common challenges. A lot of them are not disease specific, and there's loads of types of support that are going to benefit basically all carers, regardless of disease. I think a few things that are specific that have come up for us, I'll just talk about COPD carers specifically, is that the breathlessness itself is a really particularly almost existentially distressing experience. And that experience of watching someone you love sort of not being able to breathe is really difficult. And that's not specific to COPD, actually, that goes across a lot of different contexts. And then another aspect is the stigma around respiratory diseases. And I think that this applies to certain other areas as well. But there is a perception from COPD patients and their carers as well that you hear a lot, that health professionals are assuming that they're smokers, that it's their fault and that they don't get enough attention. Whether or not that's true and that professionals are thinking those things, we're not completely sure. So that would be something to dig into as well. But I would say, yeah, that stigma piece has come out quite strongly in our discussions as well. Yeah.
Great, thanks, Minera. And Bethan.
Hi, Eleanor. Really good, interesting talk. And we've talked a bit about training before in other populations. My question is around what training you think can be done online through websites, information, videos, and what needs to be face-to-face, either through kind of one-to-one training, possibly group training, or even simulation training, certainly with parent care. There's quite a few papers now around tracheostomy and ventilation care around simulation training with parents. I'm wondering if that came up in the COPD population.
I will say there's probably not loads that I can say about this because I'm definitely not an expert in either training or designing digital interventions. I would say that my expertise is around talking to people and getting some really deep insight into their experiences. But around that, what we've heard from carers that they sort of want most around training and knowledge is similar to other carers around knowing how the disease is going to progress in the future and how they can sort of practically make plans for different scenarios that might happen. And I could definitely see that being delivered digitally. And then also around some sort of specific non-pharmacological techniques for breathlessness that we think we know are really valuable when we teach them to patients and that could be valuable to teach to carers as well. And those can definitely be conveyed through digital means. We are hoping that that sort of bears out in the self-breathe trial that's happening at the moment. I think it will depend a lot on individual carers. People learn in different ways. And so a lot of this will be about figuring out, you know, the groups that are most impacted by this, how do they need the information delivered to them? And if it turns out that there's a really huge sort of, you know, digitally excluded group of people, and they're the ones that really need additional training and support, then we might have to pivot on that and think about how we can beef up in-person services. But yeah, definitely other people on the project team who might be better placed to chat about sort of specifics on that. But thanks so much.
Thanks, Bethan. Are there any other questions or comments for Eleanor on her ConnectCare project? Just checking the chat and the Q&A, but I think they relate to my presentation. No? Okay. Thanks, Alan. So I'll try my best to respond to, let's see, let's take the Q&A ones first. Karina, in terms of a website or a project or a place, yes, we have a website for the project. I think Ollie's on the call. Ollie, if you get a chance, perhaps you could respond to Karina in the Q&A with the link to the website. But yes, there is a website. It's a little bit out of date because it's not doesn't take account of the workshops we did recently in London and in Denmark. But other than that, it's up to date, and that's where, when we digitalize the resources, that's where they'll be freely available. I should have said that all of the resources will be freely available under a Creative Commons license, so they'll all be completely open source once we've digitalized them. Yeah, Ollie, I think he's already posted it, I think. Yeah. Oh, sorry. Yes, that's the research page at King's. That's I think Abby's posted. We also have a project website that Ollie's going to add to the Q&A. And I think both Eleanor and Lucy's comments pick up on the same point around the systemic perspective that Ursula's work brings. And it's interesting that you should both ask questions about that, because that's one of the things that really appealed to us when we landed on her work, was that systemic perspective that's kind of represented particularly in her principles 7 and 8. So the principle 7 around minimal recognition of rights to organise, and then Principle 8 for groups that are part of larger social systems, etc. So Erstrom had this notion of polycentric systems, as you're probably aware, and that every sphere of activity has a kind of optimal scale within those systems. So one of the things that we found very interesting with the, as I briefly mentioned, with the retrospective study of the LA work with formerly incarcerated prisoners, was that that was a very complex system that co-design project was operating in. You know, a huge number of third sector, federal, state organisations involved in health and social care, and trying to navigate that through that co-design project for these for this population was extremely complex. And it was clear that the co-design project hadn't really in any way sort of addressed the types of principles and practices that were represented by those principles from Ursula's work that they'd missed, they hadn't covered. So I think that systemic perspective is something that's potentially of real benefit when we're thinking about how we scale up the value of co-design projects and co-design initiatives. There's more about that in the LA paper. We reflect on that a bit more there. If I get a chance in the meeting, I'll pop it in the chat, the reference. Let me see, and then I think there's a question from Richard in the chat as well. Yeah, about proposals for researching and evaluating our novel methods. So we're actually just beginning to formulate a proposal for the NIHR call for better methods, better research, which is due in beginning of July, I think, to do exactly that. It's going to be case study based. We're going to be doing some prospective longitudinal work, pretty similar to the work that we did with the user-led organization group, but now with our much more clearly thought through and formulated tools and resources. In terms of sort of evaluation design and study design, we're still knocking that about at the moment as we try to work up the better methods and better research. So any tips or advice would be very welcome. I know Ollie may want to come in on that, but I can't see any other questions or comments in the chat. Were there any more questions or comments that people wanted to raise in the meeting? Just raise your hand. That would be great. No? Okay, I can't see any hands or any outstanding questions or comments. I will, before we end, just post that link to the LA retrospective study so Lucy and Eleanor can see that. Okay, any more questions or comments? Thanks, Eleanor, very much for your talk and taking the time. And thanks to all of you for attending and your comments and questions. We wanted to give a brief shout out to our next webinar, which will be on the 3rd of July. It will be presented by Jerry McGibbon, who's Professor in Public Services Management and Organisation at King's. And the title of Jerry's talk is Temporal Ambiguity in Inter-Organisational Collaboration Processes. So quite closely related to some of the things that we've been talking about in our collaborative group working talk. Abby's posted a QR code on the screen, a link, and is going to post a link in the chat. Please do share your feedback with us. And if you're interested in Better Health and Care Hub, please do follow us on the social media links that Abby has also posted in the Q&A section about our latest news and activities. And I think that's it. Okay, great. Look forward to seeing you at the next webinar. Thanks very much. Have a good rest of the day.